Hello, online students. We are going to be talking about diabetes, and as we're talking about diabetes, we are going to take a three-part adventure, and it will be an adventure. The first part's short and sweet, second part's pretty deep, and third part's pretty long. That would be how I would describe our adventure. I have put the objectives up. Please make sure that you review the objectives so you know what's expected of you for this week. And I will also and of course, don't forget in the discussion area, you can post any questions or concerns, and I will put up a little area in there that says questions and concerns related to diabetes content, so that if anyone needs to post something, I will be happy to answer it. So let's start on our first part adventure. Alright, I will have this posted so that you will be able to print it off and follow along with me. Also, you'll need to get your Med-Surg book out if you don't have your Med-Surg book out, so that we can go along with this together. So, diabetes mellitus part 1. When you talk about diabetes in general, it has become an epidemic problem almost. So it is something that if you have not had much contact with your patients, you surely will in the future. So it's very important that you understand diabetes. For reading for this exam, your Med-Surg book for just the diabetes part of endocrine will be chapters 64 and 67 out of your Med-Surg book. Pharmacology book will be chapter 57, and your PEDS book will be chapter 29, pages 992 through 1006. So hint, hint, theorist anyone? It's kind of like the lions and tigers and bears and theorist. Oh my. Pharmacology for sure. Delegation and lots of it. Levels of prevention, always. And Tanners, oh yes. Why, oh why do you do this, Miss Candler? The reason we keep going over and over and over this stuff is because you will forget it from semester to semester if we do not. So repetition is the mother of all learning. So thinking about the anatomy and physiology of the pancreas. Actually, the endocrine system, if we think about it, has glands or glandular tissue that does what I call the 3 S's: synthesize, store, and secrete. So it does the 3 S's: synthesizes, stores, or secretes. And it does this through chemical messengers or hormones that travel through the body to a target cell. The pancreas itself is triangular. It lies behind the stomach and is anterior to L1 and L2. It's only about 6 inches long and 1 to 2 inches wide. Weighs about 60 to 90 grams. Even though it's small, it's potent. It has a lot of things that can go wrong if something goes wrong with the pancreas. It has both endocrine and exocrine functions, and insulin secretion begins early, in fact, around 20 weeks gestation. There are 2 types of functions of the pancreas. One is the exocrine function. This is the gland that secretes substances directly onto a surface or organ into a duct. The pancreatic enzymes then are secreted via duct to the duodenum. The endocrine system is a gland that secretes substances directly into the blood. So like the beta cells secrete insulin directly into the bloodstream. So it's ductless. So what is the main difference between the endocrine and the exocrine function? The main difference is in the exocrine function, it is a duct system, and the endocrine function is a ductless system. And that is our main difference. So food for thought. And we're going to be focusing on the dysfunction of the endocrine gland function of the pancreas. We're not going to be talking about the exocrine function. We're going to be talking about the endocrine functions. So when can these disorders occur? Well, if you looked way back just a few pages ago or slides ago, we did talk about when it begins, 20-week gestation. So really at any age, including the fetal and neonatal periods. So let's talk a little bit about the islets of Langerhans. There are 3 distinct cell types. One is the alpha, and they secrete glucagon. Now we're going to be talking a lot of G words, so make sure that you understand what I call the G words. The second type is B for beta cells, and they secrete the insulin. The last ones that you're going to have to worry about are the D cells, or the delta, that secrete somatostatin. Now, it is very convenient because there's A, B, and D, A for alpha, B for beta, D for delta. There is also a good visual in your book on page 11, that's page 1364. So I have turned over to page 1364, and if you look on page 1364, it shows you the pancreas. Then it will show you the cells of the islets of the Langerhans of the pancreas. Actually, it shows you a picture of the alpha cells, the beta cells, and the delta cells, so that you will know what they look like as well. As far as functions of glucagon, and just know also that your body, we have about 1 million islet cells, so we start with a whole lot. Looking at functions of glucagon, we know this is a hormone that has actions that are opposite those of insulin. They are also called counter-regulatory hormone. Glucagon is a counter-regulatory hormone, and what that means, it counter-affects something. In this case, it has the opposite effects of insulin. It releases glucose, another G word, in the form of glycogen, another G word, from the cell storage cells whenever blood glucose levels are low. So we have glucagon, and we know that from the slide before is secreted by the alpha cells and from the cell types of the Langerhans. Then you have the other G words here. You have glucose, because that's what it releases. And then you have how it's stored in its storage form, and its storage form is glycogen. So a lot of G words to keep straight. So let's talk about a few more G words. Okay, gluconeogenesis is the formation of glucose from non-carbohydrate sources, so things like fats, proteins, and this would help you with long-term needs. So when your body's starving, what's it start doing? Breaking down fats, breaking down proteins, and it's turning to long-term needs. Now, glycogenolysis is the release and conversion of stored glycogen, remember that's how glucose is stored, formed, glycogen, into glucose from the liver and muscle cells. And this will get you through your short-term needs. So, the question of the day is, when would glucagon be released from the alpha cells? And the answer is anytime we need to protect the body against hypoglycemia. Anytime we need to protect the body against hypoglycemia, because what's it going to do? It's going to go to the storage cells in the liver and the muscles, and it's going to convert that glycogen that's in the stored form back to glucose into the bloodstream to raise that sugar back up. Now, there are other counter-regulatory hormones in the body as well, counter-regulatory hormones that also help increase blood sugar levels. The other ones would be epinephrine, norepinephrine, growth hormone, and cortisol. The other counter-regulatory hormones would be epinephrine, norepinephrine, growth hormone, and cortisol. So this just puts it for you visual folks in this format. We have glucagon, which is the hormone whose actions is to increase blood sugar levels. How can it do that? Through short-term or long-term needs. If we go the short-term needs, then it's going to be called glycogenolysis, and that's when we stimulate the release and conversion of glycogen, which is our stored form of glucose, back into glucose from the liver and the muscle cells. What's the result? We're going to have an increased blood sugar level. For long-term needs, we go to the other G word, gluconeogenesis, and this is the formation of glucose from non-carbohydrate sources such as your fats and proteins. How does it do this? By breaking down the fats, breaking down the proteins, and the result of that is, again, we increase our blood sugar levels. So whether we go the long-term or the short-term needs, we have the same outcome with our smiley face of increasing blood sugar levels. So what's the function of insulin? Well, insulin, you can see here, has several functions. Most of us all think about it's the hormone in the body that directly lowers blood sugar levels or blood glucose levels. But if you look here, it has lots of different duties. One, Insulin increases the uptake and use of glucose. It's the primary regulator of carbohydrates, fats, and protein metabolism. It facilitates glucose transport across cell membranes. Again, it's the only hormone in the body directly that lowers blood glucose levels. It augments the transport of potassium into cells. That is a huge one to remember, especially when someone goes into DKA, which we'll be talking about later. It stimulates protein synthesis, and it has a basal rate. That is a basal rate that's continuously released into the bloodstream in small pulsative increments. By basal rate, I mean the rate is about every 10 minutes. So about every 10 minutes, your body goes beep, beep, and gives you a small pulsative increment of insulin to keep your sugar maintained throughout the day. So that brings into mind two questions then. Number one, what happens after a meal's eating then? Well, if you think about after a meal is eaten, insulin secretion has to increase. So we're putting out a lot more insulin. Because what's that insulin going to do? It's going to move that glucose that's in the bloodstream into the muscle, into the liver, into the fat cells, and store it in the form of glycogen. So now the blood sugar levels overall are going to decrease, and that's going to facilitate a stable, normal range for your glucose. So what happens after a meal's eating? You increase your secretion of insulin to help move the glucose into its stored form. Now then, what happens then between meals and overnight to keep us regulated? Well, between meals and overnight, we have what's called the buddy system. If you think about insulin, we said the main counter-regulatory hormone to insulin was glucagon. Glucagon. Glucagon works together to maintain a constant level of glucose. So you've got some that's secreted from the alpha cells, some secreted from the beta cells, and together insulin and glucagon work together to keep the body's level of sugar maintained. So when it goes up, starts going up, a little bit of more insulin is going to be secreted. When it starts going down, glucagon is going to kick in. It's going to go to the liver or wherever those stored forms are and convert that back to glucose and spit it into the bloodstream. Just an FYI, the average amount of insulin secreted daily by an adult is about 40 to 50 units. Now, if it's a larger person, it will be more than that. It will be about 0.5 units per kilogram of body weight. Insulin usually won't drop your sugar with a normal person, below your 80s to keep it maintained. And glucagon kicks in when it gets in around 60s to keep it maintained. So again, there's that buddy system of helping out there. So what effect does insulin have on the central nervous system? The central nervous system we know is permeable to glucose. In other words, it does not need insulin to transport glucose into the cells. Hyperglycemia does not damage brain cells. Very important to remember. But cells cannot survive with a glucose deficiency. Thus, the central nervous system stores only a minimal amount of glycogen. If you remember, that's the stored form of glucose. This is important to remember. Very important statement I'm saying here because it helps with answer this question then. With this in mind, answer this question. Which one of the following patients or clients would you see first? Mr. Smith, who has a blood sugar of 50, or Mr. Jones, a blood sugar of 80, Mr. Tom, a blood sugar of 160, Mr. Carter, a blood sugar of 300. You should have picked Mr. Smith with a blood sugar of 50. Why? Because we cannot survive without that glucose. You will start damaging brain cells with hypoglycemia, but not hyperglycemia. So what's the functions of somatostatin? This one was the one secreted by the delta cells. It's released in response to hyperglycemia and hypoglycemia. So it kind of helps both insulin and glucagon. It is theorized that somatostatin also allows the influx of glucose into the cell after a meal, and that helps prevent postprandial hyperglycemia as well. What about assessment? Well, assessment is a very key, important component when we think about diabetes. First thing you're going to have to do is take a very good history, and we start with our subjective data. We're going to be looking at biographical data, the age, their height, their weight, gender. The chief complaint, it can range from specific to non-specific. Appetite changes, weight changes are key. Increase in thirst and urination are key. Past medical history, family history, what kind of medications have they been on? Psychosocial history and lifestyle stressors. Looking at coping patterns, support systems, belief and value patterns, because all of those things here that we're talking about can have an impact on your blood sugar level. Just an FYI, medications, glucose-lowering ones, some of the more common ones that affect glucose and lower it is Tylenol. Most people don't know that. Beta blockers, of course, insulin goes without saying, and tricyclic antidepressants can also affect it. Now, some of the things that affect glucose by raising it that people aren't aware of is caffeine, barbiturates, birth control pills, corticosteroids. That's why we have to taper you off of them, because you know they cause very high levels when you're taking them with someone with diabetes. Lasix, lithium, and epinephrine. A good history, objective data. You're going to do a look at the physical exam. You're going to look at inspection, palpation, and percussion, and auscultation are not part of the normal part of the endocrine system. It would be very hard to percuss the pancreas and auscultate the pancreas, in other words. So we're going to be inspecting. We're going to be doing a general head-to-toe assessment, especially looking at the skin, feet, and eyes of a diabetic. Three main components you always want to look at: an overall assessment of their skin, a good assessment of their feet, and a good eye exam, and then palpation for any nodules. So this was the short and sweet version, as I promised. This is the end of part 1 that covers the A&P and assessment. If you have any questions or concerns, you'll have to just speak up again in that discussion board, or forever hold your peace. I'm just seeing if you're reading this, or daydreaming, or texting, or catnapping, or la 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 land. All right, so before we get started, just on the next one, just a couple more slides to get us to where we're fixing to be going. One of the things you're going to have to get in your mind is the difference between type 1 and type 2. On page 1417 in your book, there's a differentiation of type 1 and type 2 chart. And I've also made a visual for you as well here. You will need to know this table. With type 1, it usually, we see this in our young people, younger than 30, and the peak age is actually 10 to 15 years of age, with a peak age of 10 to 15. The signs and symptoms usually come on abrupt with type 1. They can be fine one day, and the next day they can have increased thirst, increased urination, increased hunger, and end up with type 1 diabetes. HLA typing and virus, there is a relationship with HLA typing and viruses. The islet cell antibodies are going to be positive for type 1. Usually they have no insulin whatsoever to help with them out. So they have no insulin. They have destroyed the beta cells. Usually they're quite thin. They may or may not have the 3 Ps that we associate with diabetes: the polyuria, the polydipsia, polyphagia. So then they also may have fatigue, or may not have fatigue, depending. I'm sorry, they do have the 3 Ps. I said didn't. Excuse me. This is type 1. They do have the 3 Ps and the fatigue. In other words, they have the increased urination, the increased thirst, and the increased hunger. That's our 3 Ps, and fatigue. They are prone to ketosis, means they will break down ketones. You can control them with insulin, diet, and exercise. And you find type 1 equal in males and females. So usually are young, peak age 10 to 15. Signs and symptoms come on abruptly, related to HLA typing and viruses, and we'll talk about this more in depth later. They're going to be positive for antibodies because they think it's autoimmune. Usually no insulin, thin. They have the 3 Ps in the fatigue. They are prone to ketosis and usually controlled with insulin, diet, and exercise, with males and females being affected equally. With type 2, usually they are greater than 30 and actually usually peaks in their 50s. It comes on very slow. No relationship to HLA typing. Islet cell antibodies are negative. In other words, they don't think it's an autoimmune. They will have some insulin on board. That's why we can take PO pills to help control it. They're usually obese. They may have fatigue and other symptoms, but not necessarily the 3 Ps. They are resistant to ketosis, and we'll talk about that here in just a little bit. And part of that reason is because they do have some insulin. They had no insulin with type 1, but now they have some insulin with type 2, so that prevents the ketosis. They're usually controlled with exercise, medications, and unfortunately with type 2, we are also seeing some of them having to be controlled with insulin. Females are affected greater than males. I'm not sure if they're saying there's more females that are obese, or I'm just kidding. There really are. But type 2 peaks again in your 50s, and about 20 to 30% end up on insulin, which is kind of scary. So here's another visual. If for you visual folks, type 1 diabetes, signs and symptoms. We got someone coming out of the restroom. They've got a McDonald's burgers to go, and they have a drink in their hand. So that's our 3 Ps. Polyuria, increase urination. Polydipsia, increase thirst. And polyphagia, increase hunger. So those are your 3 Ps that are common with type 1. Also, weight loss, fatigue, increased frequency of infections, rapid onset, insulin dependent, familial tendency, or that's because of the HLA typing, which we'll talk about here in just a little bit, and peak incidence, it's 10 to 15 years of age. Type 2, I am so mad. They took a picture of me without my permission. I'm just kidding. But this is a typical prototype of type 2. And for those of you who do not know, I do have type 2 diabetes myself. When you look here, sedentary lifestyle, familial tendency, and this one is hereditary. So with type 1, it is not hereditary. Type 2 is hereditary. You need to get that in your mind. Type 1 has to do with some HLA typings. Yes, if you have certain types of HLAs, you have a greater tendency. But there is actually a hereditary link with type 2. The average age is 50. You have a history of increased blood pressure, fatigue, low energy, obese, recurring infections, polyuria, polydipsia may or may not be present, and fasting blood sugars are greater than 126 milligrams per deciliter. So our typical picture here, you've got someone popping the chocolates, and they've got their antihypertensives, their antibiotics, they're all bandaged up, they got the sore toe, and they look like they have the typical sedentary lifestyle. So that just gives you some visuals. Delegation tips when we're going through this test. CNAs can reinforce education and teaching, but cannot initiate it. Stick to basic skills CNAs can perform. They don't do consultations. They don't do IVs. They don't give meds, dressing changes. So think about what a CNA does. The LPN. Now, they can also reinforce education and discharge teaching. Observation skills, not assessment skills. If they observe something's not right, then they should notify the nurse, the RN, or the charge nurse. IV meds, not in every state. IV meds require usually further assessment. So you have to be careful about assuming that LPNs give IV meds in all areas, because it just depends. Again, stick to the basic skills that you think of when you think of the LPN performing skills. They do wonderful observation skills. They do PO meds, subcutaneous meds. They do dressing changes. They assist the CNA. They assist the RN. They reinforce education and discharge teaching that's been done by the RN. All right, grin and share it. Bury them. What do we do with the body when a patient dies? We bury them. Dilate is to live for longer when you dilate. Fester, quicker. Labor pain is to get hurt at work. Morbid is a higher offer. Morbid. Nitrates is cheaper than the day rates. Node was aware of. Rectum dang near killed him. Urine is the opposite of you're out. So just some funnies. All right, that's the end of this section, and you can call me if you have any questions. You can have any concerns, you can email me, and it was a pleasure, and I will get with you on part 2 shortly. Thank you.